Good morning. My name is Jim Stanger, and today I'd like to briefly review a paper looking at the autologous versus donor oocyte embryo transfers for euploid embryos. It's basically a summary of a paper that occurred a couple of months ago in Fertility Society Reports in August 2025. Live birth outcomes after euploid transfer, autologous versus donor oocyte embryos in patients over 35 years of age. And there is the URL if you wish to look at it. So what do we know? So these basically are quotes from the paper. Anything inverted commas is a quote, and I acknowledge the authors for this. Basically said that as female age increases, both fecundity and the ability to conceive using assisted reproductive technologies with autologous oocytes decline. This is primarily because of an age-related increase in meiotic errors during oogenesis. That's when the oocyte's being made, which results in embryo aneuploidy, that is the wrong number of chromosomes. However, it is suggested that increasing female age may also result in other pathological changes that could contribute to this inverse relationship between increasing female age and pregnancy. It stands to reason that if embryoploidy is the only age-associated exposure associated with live births, euploid embryo transfer outcomes should remain stable as age increases. Alternatively, if there are additional age-associated pathological changes that are associated with live birth, then a significant inverse association between increasing age and live birth should persist even in analysis restricted only to euploid embryo transfers. Therefore, the live birth rate should either fall or remain the same, with increasing female age using either autologous or donor oocyte-created euploid embryos. So before I get going, I need to give a bit of a culture shock and just cite an article that the authors cited, an article done in Fertility and Sterility in 2023, looking at maternal age and reproductive success rate and meta-analysis. These are forest plots. The first one is live birth rate. This is implantation rate, and this is miscarriage rate. And just this, I think I'll do a separate YouTube video on this because this is quite important. But essentially, a highly significant association with pregnancies for women under 35 compared to over 35, a highly significant association between higher implantation rates for younger women than for older women, and a highly significant increase in miscarriage rates for older women compared to younger women. So in other words, there is already established in the literature considerable definition that increased maternal age is associated with a decline in ART success rates independent of embryoploidy. So this is data. There are several tables in, I think, that it's open access, so you can read it, or it's free anyway. So this is the results, and I'm only summarizing what they've written. And basically, they've said that they've looked at 15,000 single euploid frozen embryo transfers, both in natural and artificial cycles. They're analysed, including almost 14,000 autologous and 1,100 donor oocyte cycles. These are okay. The mean age for the autologous oocyte retrieval was 38 years. That is the age of the eggs, and collected were 38, compared to 27 years for the donor-derived oocytes. The live birth rate occurred in 55.8% of all autologous transfers in the age group 35 to 37. That's seriously impressive. That's almost 60%. This is live birth too. This is live birth, amazing. But there was a linear decrease in live birth rate as the age group increased. So 55, 52, 48, 47, 45. Sorry, 58, 52, 48, 47, 43. It may be a fall, but even look at this over 45-year-old women using their own eggs, putting back the transfer of one or two euploid embryos, 44% live birth rate. That's amazing. Amazing. The live birth rate occurred in 49% of donor oocyte derived euploid transfers, but as the age increase of the recipients increased, the live birth rate remained the same, 49, 47, 45, 45. So there was no significant difference in the donor oocyte transfers compared to the autologous ones, which fell, but I have to say they're all spectacular. And the interesting thing for this one was for the reference group 35 to 37, the donor oocyte group was significantly poorer. That's a topic for a bit further on in the talk, but it may just be a function of numbers, or there may be something which is far more important in the talk in this bit of data compared to everything else. So for the donors, it was 37 compared to 55, for 38 to 40, 49 to 52. It's still pretty impressive. Okay, so that's the data. What did the author say about it? For autologous cycles, there was a linear decrease in live birth rates as age increased, down to 44% amongst patients over 45, which is still spectacular. The clinical pregnancy rate significantly decreased as oocyte age increased compared to the reference group, and there was the increasing age was also associated with an increased risk of spontaneous abortion. Although I talk about the clinical biochemical rates of this, and I think that's something which I'm not quite sure of, although the p-value of 0.08 tells you it is almost significant. The donor oocyte cycle outcome, the live birth rate occurred in 49% of euploid transfers in the 38 to 40-year-old reference group. However, across all age group, there was no statistically significant decrease in live birth rates, p of 0.5, which means there's very little. Furthermore, there was no statistically significant difference in the age groups for any of the secondary outcomes, including positive HCG, biochemical loss, spontaneous miscarriage, abortion, and clinical pregnancy rate. Okay, so that's the data. What do they say? And I think this is the crux of the talk. The aim of this study was to investigate the potential association between embryonic and non-embryonic factors in the declining likelihood of live births with increasing maternal age, comparing autologous euploid FETs to donor oocyte-derived euploid embryo FET outcomes. The authors note that we observed that amongst the autologous euploid embryo transfers, there was a significant linear decrease in live birth rate. And this has been observed in previous cohorts or publications. However, amongst the donor oocyte-derived euploid embryo transfers, the chance of live birth remained largely comparable and statistically did not decline as maternal age increased. Therefore, increasing age is most associated with chromosome segregation errors at meiosis, mainly caused by premature separation of sister chromatids and reverse segregation. I don't need to go into that here. It is known that the increase in embryo aneuploidy is associated with increasing maternal age as a primary cause of decreasing live birth in these patients. However, even amongst euploid embryo transfers, there is a small but clear inverse association between maternal age and live birth. And the important thing for here is small and clear inverse association. There are two plausible explanations for this, which the author suggests. One is an increase in abnormal embryonic factors, genetic abnormalities not detected by PGT-A for aneuploidy, epigenetic changes, or aberrant changes in transcriptomics and metabolomics, or alternatively, an increase in non-embryonic factors such as uterine vascular supply, maternal endocrine environment, and endometrial receptivity. The authors say that their studies suggest that non-embryonic age-associated decrease in live birth rates after euploid transfer is secondary to the abnormal embryonic factors, given that the live birth rate was observed to decline only as the oocyte age increased. But so what will be these non-embryonic factors that they're talking about? If they looked at uterine factors, the live birth rate for donor oocytes over a range of maternal recipient ages suggests that there was no age-related uterine factors. The authors also noted that the age of the oocyte donors was in the mid-20s, but the partners of older clients they were usually also older. Male partner age increased alongside female partner age and was similar between the autologous and donor oocyte groups. So the donor oocyte group, despite also having an increase in the age of the male partner, did not show a corresponding decrease in live birth. In other words, because the donor oocyte live birth rate was the same, it suggests that the male partner had no role in the decline seen with autologous. More interestingly enough, they looked at the day of transfers, and the authors noted that very few day 7 embryos were transferred across all age groups in a cycle. However, the proportion of day 6 transfers increased with age in the autologous group, but was not associated with age in the donor cohort, indicating that blastulation timing may be one of the oocyte age-related factors or a proxy of one of these factors that impacts on transfer success. And they looked at embryo morphology, and this is a bit sort of wafty, but basically they said most transferred embryos were graded as good quality regardless of age group or cycle type, reinforcing that embryo morphology does not fully explain the age-related decline in live birth rates in autologous cycles. But I thought this one was interesting. That is, the embryos were just developing a little slower, and being slower starts to impact on likelihood of live birth. So just to summarize it, so there's a fair amount of repetition here, I know that, but it's like reinforcing the fact. Among patients aged 38 or over who transfer a euploid embryo, the live birth rate declines with increasing age when autologous embryos transfer, but not when a donor oocyte-derived embryo is transferred. Therefore, age-related uterine factors does not fully explain the decrease in live birth rates with increased maternal age. The factors related to the age of the oocyte, such as cytoplasmic competency or epigenetics, even in euploid embryos, are more likely to explain these results. So underlining oocyte and embryo quality. So my comments on this finally at the end, if you've persevered this long, while the autologous live birth rates fell with increasing maternal age and the donor rates did not, I have to say the rates were still very, 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 very impressive for both groups. This to me shows that the transfer of euploid embryos in older women overcomes almost all the problems of maternal age. And even though I may be a critic of excessive use of PGT-A and day 5 transfers, biopsy, PGT-A, cryopreservation, and transfer back into largely artificial cycles, I'm criticised at that. You have to sit back and look at these success rates and think seriously impressive, particularly over 45. The observation that autologous euploid transfers still has a significant miscarriage rate tells me that while the embryos may have the correct chromosome number, there remains other factors in older eggs that will cause pregnancy failure, such as mitochondria, etc., or a latent implantation issue that may include age-related response to pregnancy. So I'm saying there's a uterine, but there may be a uterine embryo interaction that's age-related. There have been several articles indicating that paternal age, especially in donor oocyte transfers, is not related to live births, and this data reinforces that observation. And lastly, you have to remember that these rates are per transfer and not egg collection. So it's unclear how many clients fail to get to transfer. So when we talk about a high pregnancy rate for women over 35, I suspect that will be carnage amongst other women who just didn't get there. And I might suspect it will be in the 40 to 50, 60% of all clients over 45 did not get to transfer. I also like to make a comment that we must remember that oocyte donation cases have a reason for using donor oocytes, most likely to do with poor ovarian reserve. This makes the results even more impressive, but may explain why the younger cohort has a poorer outcome. The authors note this, but the data does argue that using donor oocytes for younger women and for older women may not be the same. Application for older women is largely about few eggs being recovered, a collection of poor embryology, that is declining fertility. However, the application for younger women may be due to other factors, including severe premature ovarian failure, reproductive immunological issues, etc., and may also suggest other underlying reproductive disorders that reduce the likelihood of implantation. It does suggest that treating younger and older donor oocyte cases as different cohorts may be of value and is something that needs to be discussed at counselling. So younger women coming and using donor eggs, you need to be recognised that in fact the results may not be as good as the clinic might suggest. So I'd like to finish up here and say that my name's James Stanger. I'm an embryologist with more than 50 years experience. I'm not a medical person. And this information is not medical advice, but it may help you knowing what questions to ask about your treatment for your doctor and maybe helping to understand the advice you receive. If you like what I'm doing, press subscribe, press like, and tell everyone else how good this service is. I'd also have a quick plug for my other thing, which is an online EQA program in IVF for andrology and embryology at ferdate.com. And if you're interested, you can pursue that or contact me. At this point in time, I'd like to stop. I'd like to thank you for listening to my talk. There's a personal, I understand IVF is a personal journey that involves the action of many people, techniques, and ideas. It does help to understand all aspects of that journey, and I hope this information may be of some value to you. If you like the information provided, please tell other IVF clients about the service and please press subscribe. At this point in time, I will say thank you and good night.